has a very distinguished bio, and I'll just share some of the highlights. I cannot do justice to all of his accomplishments in a couple of minutes that's been allotted to me, but in brief, he graduated from medical school from Ben Gurion University and continued his training in pediatrics and pediatric GI in Israel. And he's currently the director of pediatric gastroenterology and nutrition unit at the Wolfson Medical Center in Holon, southern Tel Aviv, Israel. He has chaired the Porto IBD Research Group, which consists of 30 centers from Europe, and also has chaired Pediatric European Crohn's and Colitis Organization Committee. He has organized multiple research initiatives and guidelines and has co-chaired the Paris classification of IBD, along with chairing the revised Porto criteria. He has been on several steering committees of ECHO, and also has been participating in randomized clinical trials as a PI to ascertain efficacy and optimal dosing of drugs for PEDS IBD. He's been one of the pioneers and earliest proponents of targeting the microbiota and mucosal bacteria as a means of treatment for IBD, and his unit has championed the use of antibiotics, dietary therapies, and fecal transplantation for IBD. He has proposed novel theories for pathogenesis of IBD and has developed novel concepts regarding the role of diet in this pathogenesis. His research unit has developed 2 new diets for induction of remission in IBD, and we'll hear some about that. Last but not least, Professor Levine is the first recipient of the Pioneer Award by European Crohn's and Colitis Organization for concepts and a clinical trial in fecal transplantation for IBD and UC. And he was nominated in 2016 as a member of the International Organization of IBD as one of only 4 pediatric GIs elected to this selected and August group. I will guarantee that you all will learn and enjoy Professor Levine's talk. So without further ado, I welcome Professor Levine to share his presentation with us. Thank you, sir.
Okay, thank you. So it's an honor to be invited to this symposium and to the ICN network, and thank you for the very kind introduction, everybody. There are several disclosures here, and I would call your attention to this disclosure in the opening slide. So the information is confidential, is intended solely for the knowledge and use by attendees and shall not be disclosed or shared. And these are my confidentiality statements as well. So the objectives of today's talk are to provide you in the first part data and evidence regarding insights into the dietary science of inflammatory bowel diseases. And I'm going to be focusing primarily on Crohn's disease, but during the question period, I'll be going to take questions about ulcerative colitis as well. I want you to hope to understand the efficacy of the Crohn's disease exclusion diet and exclusive enteral nutrition as 2 different dietary strategies. To understand the possible mechanism of disease and how diet plays a role in those mechanisms, and why it is important to identify dietary responsive disease early, and this is a new term which I'm trying to have penetrate the medical world, have the medical world adopt, because I think it's pivotal for treatment strategies in the future. There'll be a short period of time for questions and answers after this first part, and then I'll move on to the second part, which will be about novel strategies incorporating the Crohn's disease exclusion diet. And I'll review some of those strategies and try to provide the best evidence that we have, and when there isn't evidence from trials, the experience that we have. So there's a lot of cynicism with diets. I get the cynicism. The cynicism comes from our experience with obesity and diabetes. We all know that it's not simple for patients to be on diets over a prolonged period of time, and this has led to a lot of disillusionment with diets for treatment of these key diseases. But I think we should try to spare ourselves that cynicism and see if we can do a better job when it comes to other diseases. But there are other reasons for cynicism with diet and IBD. And before I do that, I know that we have a mixed audience. So I'm going to talk about some of the terms that I might be using so that people understand and give us short chronology. Before 2006, we had basically 2 or 3 different types of dietary therapy. One was called total parenteral nutrition, or TPN, which is intravenous therapy. I wouldn't recommend intravenous therapy as a therapy for Crohn's disease. There was total enteral nutrition and sustained enteral nutrition, which are the same thing, which meant that you gave a patient 100% of the calories from a liquid formula, and the patients could eat beyond those 100% of the calories. And there's partial enteral nutrition, which means anything less than 100% of the calories that are required. But after 2006, we all moved to the term exclusive enteral nutrition, which means having a child because it's mostly in pediatrics, consume 6 to 8 weeks of a liquid formula without eating any diet. I'm going to show you the reason for that. And we have to acknowledge that over the years, there have been many fad or unresearched diets, and this also leads to cynicism in the medical world. And the way to overcome cynicism is to bring more science to the table. Well, what changed my practice in 2006 was an important article, pivotal article, I would say, that came out of the UK from Birmingham. And in that study, for the first time, a group of researchers randomized children with new onset Crohn's disease to either 100% of their diet from a liquid formula, doesn't matter which one, with no access to free diet, or to 50% of their calories with the rest from free diet. And both groups received the same amount of calories, protein, fat, and carbohydrate. So there was no difference nutritionally, but there was a huge difference in the outcomes. Only the patients with exclusive enteral nutrition went into remission and decreased inflammation, while in the group that received 50%, some of them had symptomatic improvement, but none had real decline in inflammation. And since then, there have been numerous studies that have evaluated exclusive enteral nutrition, again, exclusive liquid formula for 6 to 8 weeks, and the results are consistent across studies. If you take a child who's diagnosed with Crohn's disease that's uncomplicated, and you provide them with 6 to 8 weeks of a formula, 60 to 80% of those children will go into remission. I think that's pretty incredible, with no drugs whatsoever. We have to also acknowledge that dietary therapy has 0 side effects, and there are no other therapies in medicine that have 0 side effects. And a comparator at the time when these recommendations were adopted were steroids. And we know that steroids suppress the immune system, impair healing of the intestines, cause osteoporosis, and impede growth. And this led the European Crohn's Colitis Organization to adopt exclusive enteral nutrition and dietary therapy as a first-line therapy for children with non-severe disease, as long as it's tolerated. But what lessons have we learned or not learned since 2006? And this has led to some of the cynicism and poor adaptation of dietary therapy into the algorithms for doctors treating Crohn's disease across the world. Well, dietary therapies need to be evaluated in rigorous trials, and we've been lacking rigorous trials. We've come to understand that symptomatic improvement in Crohn's disease is not enough. We need to decrease inflammation and try to heal the intestines, and if we don't strive for the best outcome, we'll never achieve it. Successful diets need to show an improvement in inflammation, just as drugs are required to do if the goal of the diet is treatment and not symptoms. Unfortunately, bias is present in many of these studies, as only the mild patients are included in those studies, and only patients who stayed in the diet are included in the analysis, so anybody who didn't do well isn't included, and all these, of course, lead to cynicism. But I'm going to remind you about the principle of exclusivity, because what this principle suggested to us is that it's what you do not eat or what the patient does not eat that is driving recovery. And this is going to be very important for the coming slides. Now, I performed a study that was published several years ago in Europe in 17 centers, in which we had an inception cohort, and we looked at children with mild to moderate disease according to the guidelines, and compared those who were treated with steroids versus those who were treated with exclusive enteral nutrition. And this was the first study that actually showed that exclusive enteral nutrition is better than steroids to put patients into remission. And we also know that it's better for mucosal healing. And we also performed a propensity score analysis shown on the right. And even in the propensity score analysis, the exclusive enteral nutrition arm was superior to the steroid arm for induction remission in this group of non-severe patients. But it's not just that there's better clinical remission or better CRP remission, and I didn't show you the data from that study, but there's also better endoscopic remission. And this is a study that just looked at patients with Crohn's disease, new onset, and provided them with exclusive enteral nutrition and azathioprine for 8 weeks and performed a repeat colonoscopy. So all these children had a before and after colonoscopy. And 58% of the patients already had a good endoscopic response, which means they had a better looking colon or small intestine with less ulcers after just 8 weeks of dietary therapy, suggesting that dietary therapy indeed also heals the intestines. But I would be remiss if I didn't mention that exclusive enteral nutrition is also one of the barriers to dietary therapy. It's a difficult type of therapy to perform. And as a result, there's been poor adaptation in many places, and especially I think in the USA. The problems, of course, are that it's fixed dietary restriction. It's the same every day. There's no exit strategy. What do you do after 6 to 8 weeks? And many of those patients end up on medication anyhow, leading physicians to ask, why should I bother? But maybe there's an alternative to boring, monotonous, and tough. And I'm going to step back from exclusive enteral nutrition and historical therapies to a different approach completely. And this is based on a theory that I proposed more than a decade ago, which I still believe, I think many people believe is the best theory for Crohn's disease at the present time. And if I were to take a layman's approach and make it really simple, I would focus on this little circle here and say that the common denominator for all patients who are going to develop Crohn's disease is that they have bacteria that are lining the mucosa, which is the lining of the intestines, or penetrating through the intestines, which the body cannot clear. And once you have bacteria that are lining the intestine and entering through the intestines into our bodies, that's going to stimulate the immune system to attack those bacteria. And this will cause damage and inflammation. And this damage and inflammation will change the bacteria further to allow bacteria that can stick to the intestines to replicate and cause more mucosal bacteria to adhere. It will also compromise the barrier, allowing more to penetrate, which will then stimulate the adaptive immune response even more. And we get a vicious cycle, which is a really good model for why we have a chronic disease. And this could be driven by genetic defects, such as bacterial clearance defects, and the physicians in the audience will be familiar with genes like NOD2 and ATG16L1s and autophagy, but also by environmental factors such as diet, antibiotics, and infections. Importantly, I think there's a very important role for diet in this cycle. To understand that better, I'd like to show you this figure. On the left panel of this figure, you see a healthy individual. That healthy individual has what we call healthy gut flora or commensal bacteria. In medical terms, we call it the microbiota or microbiome. And it's very diverse and it's metabolically active, and it manufactures all sorts of chemicals that are really important for maintaining the health of the intestine and the immune system, shown in these orange boxes. And this is supposed to represent butyrate, which is a short chain fatty acid. There's a GPR43 receptor. This is the receptor for butyrate. And intermixed between these cells of the epithelial lining, these are the cells that line the intestines. We have antimicrobial cells that secrete antimicrobial peptides, which are parts of proteins, and such that if bacteria penetrate this layer, these peptides would then eradicate those bacteria and we reach a new state of homeostasis and go back to normal. And this would prevent dysregulation of the immune system. What happens in patients with Crohn's disease? And these are all documented from studies. We get a change in the microbiome. It becomes less diverse. We get an increase in types of bacteria that know how to adhere to the intestine and stimulate the adaptive immune response. And they may even reach a state called a biofilm, in which they lay on the surface or the lining of the intestine, and then they're also not reactive to antibiotics, so it's very difficult to eradicate them. We lose these antimicrobial peptides, so we can't eradicate these bacteria, and the junctions that seal the intestinal layer are broken down. We call those tight junctions. So we have a breakdown of tight junctions, so the intestines become permeable or leaky. These bacteria will translocate or penetrate the epithelium and be swallowed by cells called macrophages, which will then generate chemicals called TNF, which will then generate inflammation. And there we have the inflammation and the ulcers that we see from Crohn's disease. So all of these changes that we see in patients in Crohn's disease appear on the right-hand part of the slide here. But there's a reason that they appear, because every single one of these steps in the pathogenesis of Crohn's disease can be associated with a specific dietary component in animal models. So I can replicate any of these by changing diet. So in theory, it could be that a person reaches a state of mucosal bacteria, but then every day and every meal consumes the foods that will allow even more bacteria to become adherent or to penetrate, which will cause more inflammation, which will cause more of this vicious cycle. And we'd be topping off the cycle every day, every meal with the foods that we eat, unless we do something to interrupt this cycle. So I went on to develop the diet that I'm going to talk to you today about, called the Crohn's disease exclusion diet. And I'm very proud of the way that we structure the diet so that we become a more long-term, progressive, adaptable, modular diet. It has 3 phases. The first phase here in blue is called the induction phase. The induction phase is supposed to put people into remission and cause a decline in inflammation and also to correct the dysbiosis or the imbalance in bacteria. The first stage is the most restrictive. It lasts 6 weeks. And the principle for the first stage is it can contain no food that may be deleterious. And that may sound very simple, but there's a lot of things that we don't know yet about foods and that may have plausible mechanisms, and they have to be removed just because of what we don't know yet. The second phase is much more palatable, brings back a lot more products, including all fruits and vegetables from week 10. And then the third stage is a maintenance stage, which brings back forbidden foods. It has free meals, the ability to go to restaurants, desserts, and so forth. And this is a longer maintenance phase. And then we usually will reevaluate patients after a year. And patients who are willing to continue the stage will continue, and those who aren't, we'll put them on a personalized lifestyle, which we call lifestyle. And we haven't published data from that yet. It's important to note that I believe that our diet is the only diet that addresses the cause of the disease. And it's not directed just to the microbiome or just to the epithelial lining or just to the immune system. It's directed towards all these different components. So it's the only holistic diet, as it were, that's specifically designed for Crohn's disease. I've often been asked to give a snapshot of this diet in the first stage in one sentence, and that's really difficult because there's so many different components that are added or removed, but I would call it a high protein, low fat, low additive, and low heme diet. For instance, in the first 6 weeks, it allows chicken breasts, and I've gone through all the different cuts of meats, looking at the components at an amino acid level to choose which would be the best that would fit our theories and the microbiome, and chicken breast seems to fit it best. Eggs, potatoes, rice, fruits. Some of the fruits are mandatory, for instance, and there's a reason. Apple pectin might have a beneficial effect both on the intestine and on the microbiota. So there's a reason that apples are mandatory and you have to consume an apple every day. Vegetables, olive oil, canola oil, fresh greens. But we restrict animal fat, dairy fat, specific oils, wheat, meat containing heme or saturated fats, high taurin foods, insoluble fibers, because some patients have narrowing of the intestines and we don't want them to obstruct or have more symptoms. And then very importantly, I think we're the first pioneers to point out that emulsifiers, thickeners, and sulfites may play a role, and we remove these. I'd like everybody in the audience to understand that the success of the diet is not based on what you eat, it's based on what you do not eat. It's the principle of exclusivity. It's by restricting a person's diet for 12 weeks that allows the success of this diet. But the way it's constructed is to allow pleasure and nutritional improvement, because that's based on what you do eat. And this is what the diet looks like when you cook up all the foods according to the recipes, because we've developed a whole program. And I do have to thank Nestle Health Science, who've also contributed an app and recipes to our growing list of recipes. So when you cook these all up, there's a lot of things that you can do that are really very tasty and serve as good alternatives for things that are removed. And again, these are temporary changes because the diet improves every 6 weeks. I did the diet, incidentally, for 8 days when I was developing the diet, and so I've gone through this and I know exactly what it tastes like. This is our research program, and I won't spend too much time on this, just to say that we're trying to understand as much as we can, and each trial like this takes about 6 years, and it's very challenging to do as a single investigator. The CDED trial, which is already published, I'm going to show you the data from that in the next slides, is already completed. The adult study is already completed as well, but we're still waiting for the last patients to end their participation and have their last colonoscopies. And I can already share with you, because we're going to publish this next week, 60% of the adult patients went into remission with this diet as well. I think that's pretty amazing. We just changed their diet. The diatomics trial is ongoing right now. Already 60 children have been included around the world. And this is a longer term diet for 24 weeks. And we're looking at what we call the omics, all the different aspects of the microbiome and then the intestinal side and the immunity to try to figure out what's going on beyond what we've already discovered in the first trial. And the Paradise trial, which we just closed yesterday, so it'll launch in January 2021, is an adult trial that will take place in the Netherlands, France, and Israel. And we'll compare head to head, like the CDED trial, the CDD versus steroids with mucosal healing as the primary endpoint. And we also have an ultrasound study looking at transmural healing. So with that, I'd like to move over to the trial itself, which is the preliminary data that we have, and I have a lot of experience as well, but we're going to focus on the data. So the Crohn's disease exclusion trial was a randomized controlled trial, so it's tier 1 evidence, that randomized the diet with 50% of the calories from a formula called modulin, to exclusive enteral nutrition with the same formula called modulin for 6 weeks. After 6 weeks, patients in the CDED arm continued with CDED phase 2 and 25% of their calories from modulin, whereas this group that received exclusive enteral nutrition transitioned to 25%, the same amount of formula exactly, but gradual return to free diet that was mandatory from week 8. So there was a lot of hesitancy to go back. This was structured so we could understand if diet is driving inflammation. This is the first interventional trial to look at microbiome and intestinal barrier before and after therapy. It's the first diet intervention trial using rigorous protocol. It's both intention to treat and using the most rigorous criteria for remission. It's the first study to go head-to-head with the gold standard therapy and not versus placebo. It wasn't confined to mild patients, and there are no confounders that I'm aware of. And these are the preliminary results. On the left-hand panel, in the left-hand square here, you can see tolerance. And we showed that this was very tolerable. In the coming slides, the red is for CDED and the blue is for the exclusive enteral nutrition arm. So we can see that 97.5% of the patients found the diet tolerable, and only 1 patient left the trial because they weren't willing to continue, whereas over a quarter of the patients in exclusive enteral nutrition left the trial because they couldn't tolerate it, and there were many more that wanted to leave it, but we tried to coax them in. So there's a difference in tolerance, of course, and that's intuitive, and I don't have to explain that. But I think the more important part is in the right-hand panel here. And here we can see the remission data. And the remission was defined 2 ways. By the common endpoint for remission here, we had 80% remission versus 73.5% for exclusive enteral nutrition. This is very similar. 80% of children in this trial went to remission with regular food. I think that's stunning. No drugs. Using the most rigorous criteria that no trial usually uses, we still had 75% remission with the CDED. So again, we're very, very pleased with the results of this. Where the first difference came about was at week 12, where we saw that actually maintenance of remission and sustained remission were superior for the Crohn's disease exclusion diet over exclusive enteral nutrition. 70% of the patients had sustained remission, which means they didn't relapse, they stayed in remission using the common criteria for remission, and using the more rigorous, it was still 65%. What caused this loss of remission in the exclusive enteral nutrition arm? They were seeing the same amount of nutrition, the only difference being that they were starting to eat regular food again. And this can be seen even better from the calprotectin data. So for those of you who are not familiar, calprotectin is a measure of inflammation that we can measure in the stool. Normal in our lab was less than 50. And the first thing you can see is, these are medians. This in red here, you have the Crohn's disease exclusion diet, and in blue, you have the exclusive enteral nutrition arm. You can see that our median calprotectin was really high. It was over 3,000. So these were really inflamed patients. So this is not selection bias. These were all comers. We can see that there was a 75% decline, and it was continuous over the first 12 weeks of the study. So to 40%, and again, down to 75%. And we saw the same thing with exclusive enteral nutrition, same magnitude of decline, but something happened here. From week 7 to week 12, we had an increase, a rebound in calprotectin, a 50% increase. That's very high. And this again proves that once you start eating food, food is causing the inflammation and causing the return of the disease, clearly indicating to me that we have to have diet as part of our medical strategies in treating patients with Crohn's disease, because diet is driving the disease. We also found out that the majority of our patients will respond within 3 weeks. So these are 3-week data. 82% and 85% responded already by 3 weeks, and about between 60 to 65% of patients were already in remission at week 3. It works really rapidly. And normal CRP remission, which means there was also remission in CRP in patients who had elevated CRP declined to normal, was between 40 to 50% at week 3. This is a very rapid response in inflammation as well. So I'm going to summarize the first part of my talk and give you the clinical conclusions from this trial. And I couldn't give you all the data because we still have a lot of data that we haven't published. Crohn's disease exclusion diet induces remission, that's clinical remission, in between 75 to 80%, depending on how we define the remission. Induces sustained remission in between 70 to 75%, depending on how we define the remission. And it was superior or equivalent in every measure that we checked versus what we call the gold standard, the best therapy, exclusive enteral nutrition. So it was equal or better in every single test that we performed. But I think importantly, we identified the correct foods that are triggering the inflammation, because we didn't get the rebound in the Crohn's disease exclusion diet because we didn't have the return to those foods. And if you want to remember one number from the Crohn's disease exclusion trial, it's very convenient. It's 75%, because we had 75% sustained remission, a 75% reduction in calprotectin compared to baseline, it shouldn't be Vaseline, and 75% normal CRP remission. But we had other conclusions as well, and some that we did not, and we hoped that would occur, but we weren't sure they would occur. Specific foods appear to drive inflammation, but those foods are not included in the CDED. It appears to correct the imbalance in bacteria called dysbiosis. So what we call perceived bad bacteria, and I won't go into that unless I get questions, appear to go down, and the perceived good bacteria go up. And most, for the doctors or the scientists in the community, most genera from Proteobacteria decline to levels similar to healthy controls. So by 12 weeks, with the exception of Escherichia, all the genera from Proteobacteria are back to levels of healthy controls, because we had healthy controls. We didn't publish that in the trial. And the Crohn's disease exclusion diet appears to correct leaky gut. So this is the first diet that we have that actually has been proven to correct leaky gut, whereas modulin alone or exclusive enteral nutrition alone doesn't do that. So there's an advantage in having CDED. And with that, I'll pause right now for questions regarding the clinical trial and the science of the diet. And in the second part, we'll talk about strategies in using the diet.
All right, great. We have some questions that have come in. The first one is, I may have missed this, but were there patients in this trial or on any other therapy other than CDED or EEN? And then the second part to that, were they randomized for disease classification severity at the start of the trial?
So there are less than 10% of patients who are on stable Imuran or 6-MP. There was even less in the CDED arm, so there was about 10% in the exclusive enteral nutrition arm and about 6 or 7% that were on stable medication. All the rest were on no medication whatsoever, and there was no difference. It didn't play a role in the analysis whatsoever. They weren't randomized by severity. These were all mild to moderate patients. We couldn't stratify patients. The numbers would have been much higher. That's a good question.
Did the trial include patients with perianal disease, penetrating disease, or strictures?
Absolutely not. So the indications for dietary therapy according to guidelines right now are mild to moderate uncomplicated disease. So if I have a patient with perianal disease, which is a fistula, I'm going to try to put them on a biologic with antibiotics. And stricturing disease, you can put a patient with stricturing disease into a trial and a week later he obstructs. So that's it's better not to put those patients into these types of trials at the present time. And again, stricturing disease requires imaging, and then we'd have a delay in performing the trial. So we didn't introduce any patient who had complicated disease or penetrating or stricturing disease. And again, not sure that's where I would start dietary therapy as a main therapy. Those are the type of patients that we would prefer medical therapy in our setting as well.
Okay. How frequently were the patients seen by the dietitian for compliance?
So there were mandatory visits. So the visits were 0, 3, 6, and 12. And then there were 2 phone call visits at week 2, and I believe it was at week 8. So that the dietitians could ascertain if there were any problems with the diet, especially in the first telephone call, to correct any misunderstandings, as it were. So there was a really good support. The patients had access to, in Israel, they had access to a telephone line, a hotline. They had access to emails for the dietitians. And in Canada, they had a website in addition to all those things. So they had constant contact with the dietitians at routine visits. So all in all, 5.
Okay, great. What is the difference between the CDED and the SCD diet?
It's like I'm stepping onto a minefield. So there are endless differences, and I don't want to be negative towards anything, but first of all, I don't think carbohydrates, to my knowledge, play the most important role in the disease. So I don't understand why that would be the thing that would be the major focus. And CDD is not a low carbohydrate diet because there's ad lib rice, there's potatoes and fruits and vegetables and the modulin as well. So there's lots of carbohydrates in the diet. The theory behind SCD is the problem is fermentation, and that's what is missing in Crohn's disease is you don't get enough fermentation. So it's not a likely mechanism, and it's a standard, not multi-step diet, and it doesn't, there's no evidence that it changes the microbiota in a positive way. And since it's very similar to FODMAP diet, and FODMAP causes a decrease in diversity and decrease in short chain fatty acid producing genera, I would be cautious about recommending CDED for Crohn's disease from my perspective.
Okay, and then the last one we'll take right now. Has there been a cohort of patients who have continued phase 1 of the CDED to determine whether they have a better outcome after 12 or more weeks than those who reintroduced some foods at week 7?
So we don't have a cohort, but we do have occasional patients who relapse during phase 2 and then go back to phase 1, they do well. And since the differences between phase 2 and phase 1 are really not that great, and there are only 3 components there in the Israeli diet that would be suspect, we removed 2 of those components, and most of those patients then can progress. And I think that's giving us a clue as to which components might be driving inflammation in those individual patients. And I'm very curious about that, and it's very hard pressed to give an answer right now. Does everybody need the same diet, or could we individualize or personalize this diet in the future? And I think we could if we knew. And we tried to set up a trial that would challenge patients with individual components. And we closed the trial after 4 years. And do you want to know why? Because only 4 patients agreed to challenge themselves. So what really baffled us, but we understand, is that once the patients were doing well, they didn't want to try to eat things that they thought might be negative. They just weren't willing to go into a trial that would possibly bring back the disease. I will mention in the strategies, but I'll say it now already. A patient who's dietary responsive and after 2 years or 3 years stops the diet and flares, if they go back to the phase 1, almost all of them will go back into remission, just like the first time. And we used to say once dietary responsive, always dietary responsive, but clearly that's not the case. We have patients who the second time around didn't, but the most do. So some patients are just very dietary responsive, and that's, I think, a clue that those patients are very sensitive to diet. On the other hand, there are 20 to 30% who don't respond. So yes, we don't know everything about the diet. This is early days yet, but clearly we have to identify those dietary responsive patients. In the future, we'd like to identify what it is for those specific patients that's triggering their inflammation. So I think that we'll move on to possibly to the next part of the talk and then leave room for questions afterwards. So when doctors, when patients come to a doctor and they have new onset disease, and a doctor asks the fellows or residents, what should we do? Or if you ask IBD specialists, in fact, what you should do, you're going to get many different answers, because some will say, well, we'll give steroids or budesonide, and I'm sure that many of the doctors and the patients in the audience will identify with that. Others will say, no, I don't give steroids, I just give anti-TNF monotherapy. Others will say, well, Entyvio is the safest, let's start with that. If it doesn't work, then we can always move to an anti-TNF. Others will say, let's start with dietary therapy and methotrexate, and if they don't work, then we move to an anti-TNF. And many of our adult colleagues and our pediatric colleagues will start with anti-TNF combo therapy. And I think this is a bit confusing for everybody, and I call that pharmacoconfusional state. But this is a state that has been laid before us because we didn't choose any of these strategies. Pharma chose them for us. They develop a drug and then we implement it. But I'd like to think a bit differently, that things are changing now. The way we treat Crohn's disease, and we have to admit to ourselves, this is possibly true for most of us, is we start drug A, if it fails, we switch to drug B, if that fails, we go to drug C, and if that fails, we go to drug D. But all these drugs are basically doing the same thing, suppressing the immune system. And if you fail 3 times suppressing the immune system, maybe that's not the best strategy for that patient. So there are lots of new dietary strategies in the appropriate patient, and I'm going to say this again, it has to be the appropriate patient. And I think that in order to implement these strategies, and these are all strategies that you've been using for years now very successfully in our center, is you have to ask yourself, is the patient dietary responsive? So in our charts, it'll appear, patient dietary responsive or dietary non-responsive. And how would you know that? You give them 6 weeks, or if they have complicated disease, let's say you give them 3 weeks of Crohn's disease exclusion diet until they start their medical therapy. So if a patient is dietary responsive, doesn't have complicated disease, doesn't have perianal disease, doesn't have extraintestinal disease like arthritis, there are 3 strategies that you could start with. Not thinking about which drug, but thinking about which strategy. The first would be dietary strategy alone. We have numerous patients now with follow-up up to 6 or 7 years just on diet, never required any drugs. And it's not just the mild patients. They're the dietary responsive patients. So they go into CDD monotherapy and then CDD maintenance, and then we reevaluate them at a year. If they're doing well, and make sure they have mucosal healing. If they don't have mucosal healing, we move on to drug. If they have mucosal healing, then and they want to stay on the maintenance, they do. And we have patients, as I said, 6, 7 years, never received drugs, complete mucosal healing. That's amazing in my opinion, but it's not for everybody. The majority of our patients will be here if they're dietary responsive. They'll get a drug and a Crohn's disease exclusion diet. But what will happen is if they heal over at the end of a year, which we call complete mucosal healing, so this is sustained remission and no ulcers, we do colonoscopy, calprotectin, MRE, or capsule, depending on where the disease was. We can offer de-escalation, which means stopping the drug. And many of our patients, and in our institutions, about 40 to 50% of our patients who do this actually succeed to get off drugs for several years. But if they stop the diet, then it often comes back. So they have to maintain the maintenance diet. And then there are many patients who won't want to go on to dietary therapy because it's a limitation, or because it's impossible, because they travel, or because they're going on vacation, or they go to a boarding school. They're not appropriate for dietary therapy up front, and they'll go on to medical therapy. But many of them, unfortunately, and I'm sure that the physicians are aware of this in the audience, many of our patients will lose response and go from biologic to biologic to biologic. And now we use Crohn's disease exclusion diet as a rescue therapy, and I'm going to show you some of the data. I'm going to present 3 cases. These are all cases I saw this month. These are cases, all real cases, nothing's made up here. The first is, when I met her 6 years ago, she was 10.5 years old. She had abdominal pain, weight loss 2 kilos over 3 months. Her CRP was 24, her calprotectin was over 300, they didn't measure it. On her colonoscopy, she had ulcers and aphthous lesions in the transverse and ascending colon. And an MRE showed that there was small bowel involvement as well, terminal ileum. And the disease activity index was 30. She had mild disease. She refused steroids at the institution she was treated and came over to our institution because she wanted dietary therapy. And she commenced the CDED with partial enteral nutrition. At week 6, she was in complete clinical remission, no symptoms. Her CRP was normal. At week 12, she had regained her weight and maintained clinical remission. And in week 52, she was drug-free, sustained remission with normal calprotectins and had a normal MRE. And basically, she had normal drug-free transmural healing. She was on the diet for 3 years on the maintenance diet. And then the summer approached and they went abroad twice as a family. And then she also went to camp. That was a difficult summer. And she came back and her fecal calprotectins had gone up to 180, 300, but she hadn't relapsed. And then she repeated the stage 1 diet for 4 weeks and her calprotectin returned to normal, and a repeat colonoscopy that was performed several months later was normal. And now she's 16. I saw her last week and she's still in remission, but she's gone off the diet for the last 3 months after 5.5 years, but she's still doing really well and has normal calprotectin. So you can have patients who will succeed with monotherapy and they have that option, but it requires discipline and motivation, and this family clearly has it. But she still eats a healthy diet at home. It's not like she's gone partying, but she doesn't do the diet as we instructed her. Her calpro from last week is 57. Can you use dietary therapy for established refractory disease? So many people say, okay, diets can be for mild disease. I can understand that. I don't know how to treat mild disease. I know how to treat severe disease. We give them biologics. Well, this is a real case. Again, I saw this patient last week. At the time, he was 16 years old. He had ileocolonic disease and a perianal fistula and penetrating disease. And he was treated initially with infliximab and azathioprine, but then he lost response. He never responded afterwards to any biology. He didn't respond to adalimumab, optimized with azathioprine, adalimumab with methotrexate. And he was seen at our hospital about 1.5 years ago, and we changed his therapy to ustekinumab. And he came in, he was a primary non-responder, and he came in with a severe episode to the hospital. And so he'd been over a half a year on ustekinumab. He'd had severe diarrhea, weight loss, abdominal pain. He'd lost a lot of weight. His CRP was 120. His calprotectin was 1300. He had low albumin, I'm sorry. So what would you offer this patient? I think most of us would offer surgery because this patient's gone through all the biologics basically. And what else can you do? Well, we hospitalized him for 2 weeks, gave him exclusive enteral nutrition and then the CDED. And you can ask, why didn't he do it before? Because he refused. He was a teenager. He didn't want diet, and we accepted that. You know, we're not going to force a person to take a diet that they don't want. It was his choice, his family's choice. But this time I said, look, you're going to surgery. This is your chance. We know that this might succeed. Let's try it. 2 weeks of exclusive, 10 weeks of CDED. He was in remission within 2 weeks. His CRP went from 120 to 29 and then to normal. His albumin went from 33 to 42, and for the whole last year, he's had normal albumins. His PCDI went from 47.5 to 5 by week 6, and his calprotectin went from 1300 to 263 to normal. I just saw him now after 12 months into this, and he's still in remission, and his calprotectin is like 120. So maybe he has, and this is a patient who is biologic refractory. So as strange as it may seem, some patients, the only thing that will work is diet. And you need to think about diet when a patient is faltering. And we actually published our experience in the first 21 patients in which we did this because we kept being blown away. And this situation was such that even our adult gastroenterologists started to send their adult patients who weren't doing well to me, a pediatric gastroenterologist, to give dietary therapy because they saw the results in their patients coming back to them in remission after they came to us. So we had 21 patients, and there were 10 children and 11 adults. About 50% failed 2 biologics, 81% failed combination therapy, and all had gone through optimization. 81% had dose escalation, 60% dose interval. So all these patients, we played around with their Remicade and adalimumab to the best of our abilities. And at the end of 6 weeks, 62% of these patients who didn't respond to biologics were in remission. That's incredible. And they had an improvement in inflammatory markers in 81%. And in fact, 77%, 10 out of 13 patients that were in response continued with their biologic therapy without having to change it as long as they were on the diet. But some of these patients, when they stopped the diet, they relapsed again because they're dietary responsive. What about diet for de-escalation? And again, I saw this female this week. We had a really fun conversation. She was 16 years old at the time. She was diagnosed 18 months earlier at a different hospital, had ileocolonic disease with a long loop of inflamed distal ileum. And her doctor, per guidelines, started her on steroids and 6-MP, which is like Imuran. And she went into remission. And she was in remission 18 months when the time I saw her. And they came to me and asked, can we stop drugs we don't like Imuran? And the doctor said, there's no way you're going to stop drugs because you'll get recurrence of the disease. And I said, look, you know, if you're willing to do a diet, I'm willing to try, because in the worst case scenario, if you stop Imuran, we have other drugs, and this will be an opportunity, but I don't guarantee it. And they decided to do it. Performed a colonoscopy and MRE. She had some mild enhancement of the mucosa in the MRE. It wasn't perfectly normal, but calprotectin was good, and we stopped it. Now she's at 15 months, I think, normal MRE, calprotectin 8, and she's is 8, which is completely normal. And we've actually transitioned to lifestyle now. She's not even on the maintenance diet, so she's been on lifestyle for the last 3 months, and she's doing great without drugs. Now, I can't guarantee that she's going to stay that way, but even if she comes off drugs for 2 or 3 or 4 years, I think that that's an advantage, and she can always restart a biologic if she needs to. So if I'm going to summarize, I think we have new dietary strategies that we didn't have a year ago. We could have Crohn's disease exclusion diet and monotherapy for patients who aren't at risk and who are very disciplined and motivated. We can use combination therapy, and providing they completely heal, because otherwise we wouldn't stop it. We can try to de-escalate, and we can use diet as a rescue therapy. We have to recognize there are demographic groups that you will never respond to this diet. And these college students are really challenging. In Israel, it's soldiers as well, and high school students sometimes. People who party a lot, they're not going to keep the diet. And we have this discussion because sometimes they want the diet and they don't want the drugs, but I'm not against drugs. I'm just for diet. And I said, look, you know, are you going to be able to keep the diet? And if you don't, it's save the diet for when you need it. We don't want to have people who've been diminished or traumatized by diet that wasn't going to help anyhow because they're not going to keep it. So how can we use diet to summarize? We can use it for induction and remission, both in children and adults, as I've shown you. We can use it as monotherapy without any drugs. We can use it for loss of response to biologics. And we use it as for refractory disease before surgery, because some of our patients don't require surgery after we use it, but I'm not going to show you that right now. My time is up and I'm ready for questions, and you've been a patient audience. Thank you very much.
All right, well, there is a lot of chatting going on with quite a few more questions. So I'm going to start off with one of the physicians commented, I found that this works best when the child and parents are engaged. We have had difficulty when the parents are very interested in diet, concerned about medication, but the child does not want to do the diet at all. Can you comment on how this affects who you start on the diet?
I agree totally with that physician. I am not willing to force a child to be on a diet. And if the child isn't ready for it, we can do it at a later date. If they're doing well in medication, maybe they won't even need a diet. I'm all for diet, but I'm not for traumatizing children, because if you traumatize a child with diet, they're not going to want to pursue it afterwards. And then it'll be a short-term effect and you've lost them for a longer period of time. I do have several patients, I won't say it's the majority, who refuse diet, who come back afterwards because they do want diet because they've been through drugs or because they've had side effects of drugs. Sometimes that's a traumatizing event, but I'm for partnering. And that's the first thing we say in our initial conversation. I want to partner with you. And I think that we're really good in our institution. I have fabulous, fabulous dietitians, and they're really engaging and funny and fun. And they talk about it and say, why don't you just try it? And you want to give up, you just call me and we'll give it up, but just try it. And that's what we try. We try to get them to try it. But if the child doesn't want it, and I ask the children, are you on board or not? Because the parents will say yes. And the child will say, I'm not happy with it, or I'm depressed. And I said, okay, why don't we move on? And there are other things we can do with diet, which I'm not talking about in this talk, but we could use diet just to prevent the bacterial penetration cycle, to reduce exposure in a patient on a biologic. That's a different way to use diet. I don't have evidence for that, but that's something that we do quite frequently when a child is not willing to partner. And a lot of these children will come down the line 2 or 3 years later because they're not doing well in their biologic, and then we'll go for a short induction therapy with a diet to get them back into remission.
Yeah, so that kind of leads into the questions that came in. Did you stop biologics on any of your patients? And after week 12 or further on with lifetime maintenance, did participants need meds later on in addition to the diet?
Yes to both. So it's all over the place. So I have stopped biologics successfully, and I've stopped biologics unsuccessfully. And then there's no way that I can know. The only thing I could tell you up front is I have patients that are what we call multiplex genetic families, where there are 3 or 4 individuals in a family. Those patients, even if they go into remission, don't do well long-term. Their disease will flare and flare again, and they all go on to biologics. So if I see a multiplex family, I'll have that discussion and say, diet will work in the short term, but it doesn't usually work in the long term, and we don't know what gene you have or what mutation, but those are complex patients. Patients with arthritis. So it's really interesting that diet doesn't work on extraintestinal disease. So if you have arthritis and that's part of your disease, you're not a good candidate for Crohn's disease exclusion diet as a monotherapy. In that patient, I would definitely combine it either with methotrexate or an anti-TNF. So we do that. We've had patients who've done really well for 2 or 3 years and then relapsed because they went off the diet. And the best story that I have right now is a patient that we stopped medication. He's a musician, a drummer, in fact, and he transitioned to adults. And he was doing really well when I transitioned him on diet alone after de-escalating. And he came back after half a year to me, and he seemed to be doing really well, and his calcium was still normal. And I asked him, are you doing this? I'm doing the best of my abilities, and okay, everything's great. They showed up in my clinic a year later when he was in a flare. And the first thing that happened was, okay, did something happen with the diet? He says, well, to be honest, I lied to you. I've been off the diet for a year, but he had normal calprotectin for the first half year, and he flared again. And he went back onto the diet, and he went to the full 3 stages, and he's still off his medication. So this is a case where he's still off. But I can give you a case that's the exact opposite, where I said, time is up. I've seen you, we've done this twice already. Each time you're gonna flare again. I don't like your MRE. I think you should be on a drug. So I'll be the one who's said, I think you should be on drug. And sometimes I am the advocate for the drug. Because again, I'm not an advocate against drugs, if that's the proper terminology. I don't know if you can be an advocate against, but I'm for whatever is best for the patient. But the thing with diet is it's just another alternative, but it has an additive effect. So I think that there's always a role for trying diet in all patients at some time during their disease, but it won't be for everybody.
Yeah, I think that's, it is, it's a balance. And, you know, again, kind of partnering with your clinical team is always important to figure out all of these pieces.
I agree.
The one final question I'll send over to you is around the use of the diet in UC patients.
I don't use it in UC. I will share with you that I have a UC diet that I've developed and we're working on it. It's just a long slog to get these things into clinical trials. So we have 2 pilot trials. The data are pretty good. It's a different diet, has different principles. It's specifically designed for ulcerative colitis, and it's not going to be ready for use for a couple of years. Judging by CDED, it was a 10-year program from grants because you have to finance all these trials. And we've already launched the first randomized control trial for UC. So I don't use it in UC. I have 2 adult patients who used it and did well. I will share something that's unpublished. I don't know if I should be sharing it, but it works very well in pouchitis. That's what I can share.
All right, well, thank you all. There are many questions that we did not get to today. So our plan is to follow up with Dr. Levine and share those back with the community. And so with that, I'm going to turn it over to Dr. Saeed for final comments, and then I will come back on for final steps.
Thank you, Julie. Thank you, Professor Levine, for a very intriguing, thought-provoking, discussion-generating presentation. As you all see, we have lots more questions that we can't get to. I think my learnings have been that a couple of key points that I want to highlight is that definitely this needs to be a shared decision-making opportunity between the patient, family, and the clinical team. This needs to be done under medical and dietary supervision. We have lots of different types of audiences, and I don't want to have them go away with the idea that they can start doing this on their own at home. So this is definitely a as supervised an intervention as it would be for medication or biologics, because there could be weight issues and nutritional issues that we need to monitor so that patients are being closely followed. And I think the other key point that Professor Levine also highlighted was that choosing the right type of patient, right type of phenotype of the patients, along with personalization of interventions is critically important. We definitely, one size does not fit all, and haven't we found that out in life in more ways than one? So one treatment doesn't fit all types of patients. So I think that shared decision-making, personalization opportunity is critically important. There will be, I'm sure, more data to share as time evolves. So we look forward to that, and we look forward to other, hopefully, US sites participating in the pediatric CDED trial down the line as well. Julie, back to you. And I want to actually thank, sorry, before I give it up, want to thank our sponsor, Nestle Health Sciences, for sponsoring Professor Levine's presentation as well. So I would be remiss if I didn't do that. Thank you.
All right, well, thank you everyone for attending today. This does conclude our pre-conference symposium. Thank you all for calling in today and participating, and we hope to be in touch in the future. Have a great day. Thank you.